Hello, everybody. Welcome back to the COVID-19 vaccine podcast. This is round two. Again, I'm just going to call it that. But this is your questions answered. So we did have several questions that were submitted after watching the first video and completing the survey. Thanks for those that did that. There were a few questions that were sent in by email or just in talking. And then there were some questions too that have just popped up in general that we wanted to address. So we'll just take each question one at a time and discuss what our thoughts are on the answers. And you might see a little bit of a hard change between each question because we're going to pause the recording after answering each question just to make sure we have our notes and everything that we need on the screen. So we'll go ahead and get started. And I think maybe we'll do introductions actually before we do the question and answer, in case there are, again, people that watch this that are not within our system. I don't know if this will be widely shared or not, but Dr. Eberlein, I want you to introduce yourself just in case.
Sure. My name is Chris Eberlein, emergency medicine physician at Gunderson Health System, and the pre-hospital medical director for our region, including Tri-State Ambulance, which is a ALS transport agency in the La Crosse area.
All right. And I'm Nick Eastman. I'm the program manager of clinical services. I do quality improvement and education with Tri-State Ambulance, and been a paramedic for 15 years, and a newly anointed podcast host, which is maybe my favorite title now. These are fun, and I think we'll probably continue to do them. So the first question that came in, and actually there were multiple questions that asked kind of the same thing here. And that is, will this become an annual vaccine? Will this be a one and done type thing? What are your thoughts on that?
So they all require 2 shots. So you get the initial and the booster between 3 and 4 weeks out. And I wish we knew the answer to this, Nick. You know, right now, we hope that it is providing much longer immunity, and it looks like it is much longer immunity than the native infection that you would get if you didn't have the vaccine. And part of that is the coronaviruses in general are fairly unique, and the body does not tend to make long-term immunity to them, and that's why we can get the common cold year after year. So we don't know for sure if this is going to be an annual vaccine. I think it probably will be initially. At least that is my gut feeling. But right now, as we've only been giving this vaccine for the last 6 months, the longevity of the immunity for COVID-19 is still under investigation.
Sure. And it does seem, it is interesting if you look back to SARS-CoV-1, that virus was really only around for about 2 years before it essentially disappeared. But it was also a much smaller group of people that were exposed and infected, whereas this has clearly become a global pandemic with lots and lots of people exposed and infected, and so its ability to survive even beyond herd immunity is probably greater than that of the original SARS coronavirus. So we'll see how it goes. Maybe we'll get lucky, and this virus, after a couple of years in the wild, will just disappear, and we'll just have to wait for the next one. And I think history has proven that these respiratory illnesses, especially the coronaviruses, are likely to cause pandemics now and again in the future, maybe 5 or 10 years down the road. So hopefully longer, right?
Hopefully not.
All right. So I'm going to pause and we'll queue up the next question. All right, so this is a very interesting question, and I'm going to read it the way it was sent to us because they do a good job of using a financial analogy. So why does it matter if I have 3.8 times higher titer of antibodies if I get the vaccine? Suppose I have $1 billion versus someone else who has $3.8 billion. While having 3.8 times more money is better, both individuals have enough money to live comfortably in society. I guess that depends on how many yachts you want to buy too, by the way.
Yeah, that's right.
If I had COVID-19 and had 1 billion antibodies, assuming this number of antibodies limits the SARS-CoV-2 infection to remain subclinical if someone becomes infected with SARS-CoV-2, then why would it matter if I had 3.8 billion antibodies when both 1 billion and 3.8 billion antibodies accomplish the same goal?
This is a well-written and interesting question. And the numbers are interesting because isn't that the amount that Bill Gates is paying each of us to talk about this? How do they know? Yeah. All right. So we had to put that in there from our last podcast. Anyhow, so yeah, great question. The antibodies decline over time in your natural infection, and you may well need the 3.8 times as many as the native infection to prevent getting ill. This is a surrogate marker for your immunity. The 3.8 higher level is what very well may be needed to keep you from getting very ill or from having enough of the virus in you to be sick. So yes, in this case, more is definitely better.
Yeah, and it is kind of interesting because that 1 billion number or your baseline immunity after natural infection might be enough to keep you from getting seriously ill, but you might still get ill, whereas 3.8 times might prevent you even getting ill at all, and is much more likely to prevent you from becoming seriously ill with that number. And as Dr. Eberlein pointed out, if you want to put the financial spin on this, investing in natural immunity and really even investing in the vaccine is like investing in a stock that is going to go down. Immunity is built to a certain extent, and then it actually pulls back. It's not like you get to put 1 billion antibodies in the market, and in the next 2 years it'll be doubled. It's actually the next 2 years you're pretty much guaranteed to have less antibodies. So you want to start with the higher number so that immunity is stronger and lasts longer. All right, the next question is, does the vaccine cause facial paralysis, otherwise known as Bell's palsy?
So this is another great question because the negative possibilities of the virus are widely disseminated in the media. And so for those of you that don't know, facial paralysis or Bell's palsy is the one side of the face. It's not a stroke. It's actually inflammation or irritation of the facial nerve. And it is a fairly common stroke mimic that we see in the emergency department. And it is also a fairly common illness. It occurs in about 1 out of 20,000 people or so naturally. And what they found in the Pfizer trials that 4 people developed the condition and then 1 in the Moderna trial. And when they looked at the numbers in these trials, it was no more than what would have been expected in the general population during this time period. And the other interesting thing is of the patients that got facial paralysis after receiving the vaccine, they did not all get it on the same day. It was fairly wide distributed in time, which also leads me to think this probably is not related to the vaccine, and this is merely a coincidence.
Yeah, I think you had thrown the number out that one of the participants in the trial got the paralysis after just a couple of days after the infection, and then another one was like several months.
20 days, yeah, and then another one is like in the 40s or 50-day range. So it was very spread out over time.
Yeah, and we didn't go into a lot of detail about this part of trials for vaccines or drugs, but it's pretty amazing how detailed they track things and for what time periods. We were joking about somebody goes and gets hit by a bus 3 months after being vaccinated, and that actually might be a reportable thing. And pointed out, I kind of chuckled at that, but you pointed out a really important piece, which is, what if suddenly 20 or 30 vaccine recipients or drug recipients, anybody part of a trial like that, starts walking in front of vehicles, and then they find out that maybe it was increase in suicidal ideation or something like that. So that's not the case for this, but it's interesting to know that is, those are things that are, even those types of things are tracked.
For sure they are. They're tracking all that information because they're trying to find any correlation between the vaccine in the future that of any other disease that they may correlate it with. So you've got to report all of these things. And so some of this stuff and I'm glad they do. This is how we know our medications and vaccines are safe, because we continue to follow this data and to make sure that what we're giving our patients and each other is safe to do.
Right. Okay. All right. Our next question is, why are people having allergic reactions to the vaccine?
So, as most of us have witnessed over time, if you're in medicine long enough, you will give a medication that someone's going to have an adverse or allergic reaction to. And this is just part of whenever you inject something new into someone that they have not been exposed to, there is that small subset of the population who will develop an allergic reaction to it. And we treat it just like any other allergic reaction. It's treated with Benadryl, epinephrine, and monitoring. To my knowledge, none of the patients that have had an allergic reaction have been critically ill. They've needed the typical treatment that we have, but I believe they all went home after a short observation stay, which would be expected of any allergic reaction that we tend to have that's treated quickly. And it is interesting because, when you're getting the flu vaccine, they ask you if you're allergic to eggs. And part of that is because of the proteins and fats in the egg. And so my assumption is and we'll go over the vaccine components, but it probably has something to do with the lipids in the envelope of the messenger RNA that the body's mounting allergic response to. But that is yet to be known for sure.
Yeah, and it's most places that are administering the vaccine, including Gunderson, have taken up policies of having recipients stay for, in our case, it's 15 minutes to be monitored for any type of allergic or anaphylactic reaction. And it's not because there was such a high number of these things happening during the trial. So remember, there were I think somewhere over 20,000 recipients of the vaccine in the Pfizer trial, 40,000+ total participants in the trial, but half actually got the vaccine. And, there were very few instances of serious allergic or anaphylactic reactions. I do think it's interesting, the stories in Alaska where they had several recipients that had serious allergic or anaphylactic reactions. And that actually could be something that's a genetic situation where, they didn't have a lot of enrollees with that same genetic lineage of the folks that are living in that area of the world. And, they may be more predisposed to having an allergic reaction than others. That's the only thing that I could, a lot of the news stories there was the Boston doctor that, was on the front page and got a bunch of reviews because he had anaphylaxis. But he's an isolated case. I thought it was interesting that there was one area that had numerous serious allergic reactions. What are your thoughts on that?
I think you're right on about the genetic. I mean, we know certain things. We ask you, anyone in your family had shellfish allergies. You're more likely to have those as well. So, there is a genetic component to allergies, and we're all well aware of that. Typically, if you've got family members with seasonal allergies, you tend to too. So yeah, not surprising on that aspect, but also please realize we've given out how many millions of vaccine now? 2.8 million now, I believe, is your most recent number.
I think New York Times was reporting as of today 2.8 million doses of vaccine administered.
And we've heard of a handful of allergic reactions.
Yeah.
So, and as we give more and more, you're actually seeing that number go down, I think. So, I think this is probably in the end going to be a not unexpected number when you're injecting someone with a new medication, as far as a certain percentage of the population may well have an allergic reaction to it, but it is very, very, very small chance that you yourself will have an allergic reaction to this vaccine.
Right. Okay.
Well,
go ahead.
Much higher chance of having a bad outcome from COVID, for sure, than having an allergic reaction from the vaccine.
Okay. This next question, the person who submitted it actually talked to us and said that it was more of a joke and they wanted us to get a chuckle out of it. But there are people that believe that vaccines cause autism. And so we wanted to include this in here to ensure that we address the topic in case there is anybody who is out there that believes this. So, Dr. Eberlein?
Sure. And really, you could have a whole podcast on this one question, to be honest with you. There's a lot of misinformation out there and a lot of good information out there refuting this. But as of now, there have been no links found between any vaccine and autism spectrum disorder. So this nor any other vaccine has been linked to autism.
All right. The next question came in and asked, just curious the thoughts regarding the usage of masks and PPE on calls in the future. And this person asked, is this a year or two and back to normal after most people are vaccinated, or is this the new normal?
So I'm hoping that after people are vaccinated and this pandemic goes away, that we will have a modified new normal, is what I like to call it. Because the reality is, I think we were in general lax on PPE for respiratory illnesses in the past. And I think the usage of eye protection, source containment, such as a surgical mask on an actively coughing patient, and utilizing at minimum a surgical mask on a patient with a febrile respiratory illness should continue in the future. Will we be using this type of PPE for all calls like we are now? I don't believe so, and I hope not. But I do think that this will change the mindset for PPE and our own protection, and for the better in the future.
Yeah, I think so too. And I think if you look at, glove use is pretty much universal, which is really interesting because studies actually show that the use of gloves is unnecessary in a lot of healthcare interactions. Interestingly, a few people have pointed out, I've noticed, a lot of our folks have posted pictures of their vaccination on Facebook, which is awesome. Thank you all for sharing that. I think it helps get the message out that, we are understanding the science. We agree that it's safe and that we're willing to get ourselves vaccinated for ourselves and the people around us. But I noticed a couple comments actually on some of those photos. Why aren't they wearing gloves? And that's just basically as long as the skin is intact and there's no obvious risk of encountering body substances and stuff like that. They are moving away from the use of gloves, at least in the vaccine administration, but even in some other healthcare settings. But at the end of the day, glove use is pretty universal. I think eye protection is something that will carry on into the future on most calls. I think something over your eyes is incredibly beneficial, not just for the actively coughing patient, but ones that you might be doing, certain interventions on, the ones that are risks for spitting in your face, or coughing up blood in your face, like even accidentally. I've actually had what was considered a significant exposure where I got blood in my eyes and my mouth actually from a trauma patient who gurgled and coughed blood into my face as I was doing an assessment. The use of or the source control thing, I think, is huge. I think that will be an absolute thing in the future, that will be putting masks on patients who are coughing and are able to tolerate it. I also think that we would strongly consider wearing probably surgical masks ourselves with those types of patients. I think the use of N95s and the elastomeric respirators on a regular basis will not be the case. And masking, like in the stations and stuff, I think once the pandemic is over, that won't be a thing anymore. But people will need to make sure that they don't come to work when they're sick. And that's another piece of it. That's outside this question, but we actually don't address it here really, or we will a little bit specific to the vaccine, I guess. But that's a big piece of it, is if you're sick, don't come to work, because I think we give it to each other more than we get it from patients.
I think that's very true. And even if you're, have a minor runny nose, or, if you're not febrile and you feel like you can still work, that's the sort of time when you should wear a mask at work. if you're in that era where you're thinking, oh, is this allergies or am I coming down with an upper respiratory infection? If you're not febrile and you feel well to go to work, and I mean, I think the reality is most people can't afford to call in all the time when they feel like that, and it would be hard for an institution to have all their employees call in at that sort of level. But wearing a mask and being more open about those sorts of symptoms, I think would be good.
Yeah, absolutely. The next question involved ingredients of the vaccine. So the question essentially asked, how do the ingredients of the vaccine compare to ingredients of previous vaccines? There was a specific reference to neurotoxins. And this person also actually commented that going to the CDC website and looking this up could pretty quickly dispel the concerns about neurotoxins being present in the vaccine. So I hear right here I have the ingredients more plainly described, I guess, than maybe what you'd find in the actual EUA of the Pfizer vaccine, not the Moderna one, but they're very similar. But this is the Pfizer vaccine. So, Dr. Eberlin, what are your thoughts on the ingredients here versus some other vaccines or drugs?
So this looks very similar to most. If we just start at the bottom, the fillers, so to speak, are all very common ingredients in IV medications and vaccines in the past. The salts and the sugar, stabilizers and fillers. The upper two, the fats, the lipids, that's the lipid layer that we talk about that stabilizes the messenger RNA. So that is the area that has made this whole vaccine possible. And then the very active ingredient is the messenger RNA itself. But that messenger RNA needs that layer of fats to be stabilized to be able to be given as a vaccine. So none of this would be unexpected in a vaccine. And the one thing that is shiningly obvious that is left out of this is the tracker that the government was supposed to put in these. So another conspiracy theory that we had to talk about our last podcast.
Right. Yeah. I guess it is worth pointing out, though, if you want to actually, if we think of the question literally and how does it compare, this is the first one that has messenger RNA in it. There's no other vaccine. Now, obviously, the Moderna one also has it now, but in history, there hasn't been a messenger RNA vaccine that has made it to market like this one has. So that's not comparable, but really everything else is.
Yep. Everything else is like you said, the active ingredient and that lipid nano layer that is used are the two novel parts of the vaccine.
Yeah, and I want to just throw out there, I think I've maybe found the portions of the CDC website that this person was referencing. And, I think the two biggest concerns for neurotoxins are the aluminum salts and mercury. And really the CDC explains that, number one, the amounts of any of those things in the vaccine is so minute that the risk of them actually building up or causing any type of significant problems is very, very, very low. And in fact, many of the ingredients that are claimed to be causing problems with people are found in our everyday things like food and our drinking water and things, and oftentimes in much higher levels. So
much higher levels. Yep.
Yeah. So I think this is a good question, and maybe even an even better statement, and that is, if you have concerns about drugs or vaccines or whatever causing side effects like autism or something like that, make sure that when you do your research, because you need to make an informed decision on these things, that you're going to reliable sources, outside of some of the blogs, and Facebook posts and those kinds of things.
Yeah.
They may not actually contain accurate data.
That is correct. And also note that when Nick is talking about the aluminum and the mercury, they're not in these vaccines. Oftentimes those are used as a preservative due to the storage and the instability of messenger RNA. That is not a necessary component. So these are frozen and given quickly after thawing. So that sort of components aren't even in the COVID vaccine.
All right. The next question is, do I have to wait to get the vaccine if I've had COVID-19 already?
So you have to wait a little while. And initially it was 3 months was the guideline. And part of the reason for that is because we have limited vaccine and we are fairly confident that you are basically have immunity to COVID-19 for the first 3 months. So why would we utilize a vaccine on someone who already has some immunity when there's someone who's completely unprotected? So they should get the vaccine first. But as we're rolling out vaccine, we're already seeing that number being lowered significantly. So shortly here, and I've even seen some people saying that, once you are asymptomatic, you can start looking at getting the vaccine, or 2 weeks after asymptomatic. So I think that's probably where this will land. Currently right now, they're saying somewhere between a month and 3 months, depending on your organization and their vaccine amounts that they have. But there is not a good scientific reason to say you have to wait 3 months. This was more of a logistical reason, and as time goes on, that number will come down.
Yeah, I look at it as, Tri-State, we kind of got clinical and operations. And I think the operation side of things says wait 90 days because that gives us more doses to vaccinate those without immunity from infection. The clinical side, though, and I think it was the ACIP that actually said, essentially, once you're recovered, there's no reason for you other than operations not to get the vaccine. Mm-hmm. So there's no clinical evidence that getting the vaccine, within 15 or 30 or 60 days of having the illness will cause you clinical problems. So it's really, the wait is more of an operational thing. I know personally I've been a handful of people in our organization with that have had COVID-19 and recovered, but it's been well within the 90 days. I think in some cases it's even been within 30 days, and they've been selected for vaccination and have even gotten the vaccination. So yeah, from what I can tell, there's no clinical issues. It's more of an operational thing. So no concern there. And the last question that was submitted to us is, if I get sick after the vaccine, should I quarantine?
Yes, is the short answer to that. So for a couple of reasons. One, especially after your first dose, the protection is not to the point where it is unlikely that you would get COVID if you got exposed. You're talking between 50 and 80% efficacy after the first dose. So, and there has been cases of people who have gotten a dose and within a week have gotten active COVID-19 infection after the first dose. Now, so from that standpoint, absolutely. The other standpoint is, if you are sick, you should probably quarantine anyway, because it's going back to the whole, we need to protect each other. If it's not from COVID, if it's the flu or whatever else you have, let's make sure you don't have something else that you could give your colleagues or patients as well.
Yeah, I think it's really important to emphasize that you cannot get COVID-19 from the vaccine, period.
Absolutely.
In fact, none of the vaccines that are readily available. I think actually there's a third one now that just got an EUA, but also not using virus. So Pfizer and Moderna have no coronavirus in them. It's simply instructions for the body to make a protein that is the protein that's found on the coronavirus. So you cannot get COVID from the vaccine. If you get ill, actually, let's talk about adverse reactions too. So if you get the vaccine and you have one of the more quote unquote serious adverse reactions like headache or fatigue or fever, fatigue was the big one where they were concerned about people not coming into work because of fatigue. Yeah, stay home, because it could be a side effect of the vaccine. It could also be an illness of some sort, COVID, flu, yep, any of those things. And so yes, we want you to stay home, not come to work, and really follow the recommendations for any illness that is potentially communicable. If you are actually sick, it's the same story, right? Like if you were to have been exposed to COVID before getting the vaccine, and now you are developing the COVID, or you are developing the illness itself, or you've gotten the flu or something like that, same deal. We want you to stay home, and ideally not just from work, but from other places. And if you have to go somewhere, don't touch your face, wash your hands all the time, wear a mask, do the things that we know limits the spread of not just COVID, but also these other communicable diseases, these other respiratory illnesses and stuff. But I want to make sure that everybody understands you cannot get COVID-19 from the vaccine, period. It is not a thing at all.
That is correct. But do not be surprised, like we mentioned in the other podcast, that when I got the vaccine, my deltoid was sore for about 48 hours, and I did feel tired. I had some fatigue. I fortunately had planned my immunization when I was off shift for a couple days, so I was off anyway. And that's what our group has been trying to do, because we are just assuming that you will feel a little bit fatigued and sore. A few people have had a headache, things like that. Common effects after a vaccination.
Yeah, and it's a good point, and we'll sidetrack a little bit here on the side effects. So I also had a sore arm for about 48 hours. I didn't notice it until maybe like 6 hours after the injection.
Yep.
And then, the next day it was like, wow, that is sore. But it wasn't to the point where I was, disabled. It's not like I couldn't do anything. It was just very noticeable.
Mm-hmm.
And it felt maybe a little swollen too. I even after the pain had mostly subsided, it felt like it was just a little more swollen, or a little swollen compared to the other side. I don't think I got fatigue. I know at one point I kind of questioned, like, am I tired? Am I fatigued? It seems weird that I have to ask myself that. But other than that, I don't think I had any other side effects or adverse events. And I know that somebody mentioned yesterday or Monday that one of the other medics that had gotten injected or gotten vaccinated was at work the next day and was really feeling the arm thing.
Oh, yeah.
Yeah, but I haven't heard any other, and we've had quite a few people now get vaccinated. And I haven't heard a lot of people talk about, any serious side effects or anything. So, no concerns there, doesn't seem.
It will be interesting, because they say that the second dose, they're a little bit more magnified, because your immune system is already primed to react to this. So it would be expected you have a little bit of a heightened immune response. So, but even those that I know of that have been, at least reading about the side effects on the second one, that they're basically the same, maybe a little bit more magnified.
Sure. So that might be something worth considering. How you had mentioned trying to schedule your vaccine for time where you'd have a day off or a couple of days off before your next shift. It would be reasonable to consider doing the same thing for anybody else that has been vaccinated and is looking to schedule their second round, to try to focus on a time frame that would allow them time off.
Yeah, I purposely scheduled my next one after a 24-hour shift. So I'll be tired and won't know it anyway. I'll just get my vaccine and take a nap.
All right. So that's the end of the questions that were submitted or that we had wanted to cover. We're coming in right around 30 minutes, which is what we wanted to be. We're just a little bit over. Surprising, right? With me on the line. But is there any closing statements you want to make, Dr. Eberlein, before we sign off for the day?
No, I think we covered the questions people had, and if they have others, please feel free to reach out to us, and we'll be happy to answer them, any new ones we get.
Yeah, and I just want to say, this, I know Dr. Rathgaber has really focused on this, but this is truly a time of hope, and this is an amazing accomplishment of, as I think Dr. Eberlein said in the last podcast, the world brain. To do what we've done in the year, less than a year since the pandemic really started, and there is light at the end of the tunnel. There really, I've read some funny or really interesting things on Twitter, and somebody posted that the most serious side effect that they had from the vaccine is a renewed sense of hope.
Yes,
and I thought that was, it actually it said a lot, because I hope that people that we're reaching that point of lost hope with this vaccine available now, do have that renewed sense of hope. And if you have questions, like Dr. Eberline said, please reach out to us, and we will do our best to answer those. And especially ask if you are either on the fence or you don't think you want the vaccine. If there's anything that you, if there's a specific reason that we might be able to help address, and maybe not necessarily try to change your mind, but at least try to help you, help provide as much information as possible so that you're making your best decision, feel free to reach out to us.
Thank you.